So first I want to welcome everyone to this webinar on the case for common goods for health. We really appreciate you joining us today. And just to say, this webinar is part of an overall series as part of the Global Health Governance Building the Reset campaign. And it's supported by several networks which are listed at the top of the screen here, but Health Systems Governance Collaborative, UHC 2030, the Collectivity, the COVID Coronavirus Ethics Group, and from ourselves at the WHO Department of Health Systems Governance and Financing. And so this campaign is really meant to build a more holistic approach to rebuilding health systems in the COVID-19 area. So first, some housekeeping from myself. I'm Susan Sparks. I'm on the health financing part of the Department of Health Systems Governance and Financing. I'm very happy to be connecting with governance colleagues in this area. And I also just want to recognize Alexandra Earle and Ben Rufi-Lee, who will be active in the chat function, but they also have been pivotal in putting this all together. So this is the third in a series of webinars, and just to plug the next two, there's one on July 21st and 26th as well, and information will be in the chat box about those details as well. And just to say, this session will be recorded, and it will be put on both the Governance Collaborative website as well as the Governance Collaborative YouTube channel. And from a housekeeping perspective, you can use the chat function to submit questions or comments throughout, but also when we come to specific points for question and discussion, if you'd like to ask your question directly, you can raise your hand and the IT gods will unmute you so you're able to ask your question directly. And we'll say your name, but in the case that you don't want to say it, then you can just say pass, and that's fine. And I apologize in advance. As you can see from the screen in front of you, we have a really packed and exciting agenda. And so we'll try to keep to time as much as possible as we go through these discussions. So without further ado, I wanna start with the meat of the topic. So first I'd like to introduce, I guess I can say and also my director, Agnès Soukat, from the Department of Health Systems Governance and Financing in WHO Geneva, who's going to give an introduction into what these common goods for health are and why they're so critically important at this particular moment in time. And she'll be followed by a discussion from Professor Jesse Bump from the Harvard T.H. Chan School of Public Health, who will be talking about why action to invest in common goods for health is so difficult. And he's also going to give us some thoughts from historical analysis about what are actual triggers to actually move action forward. So I'll turn over to Agnès now. Thank you very much. And just to say, we'll also be, for bandwidth purposes, we'll be shutting off video primarily unless people are speaking. Thank you.
Thank you very much, Suzanne, and good morning, good afternoon, good evening to everybody. Happy to have you here. And as we meet and we speak right now, the pandemic most public health experts had predicted for years, the now famous disease X, has arrived. And it now threatens to become far more devastating than any epidemic in the last 100 years. Today, COVID-19 has precipitated a global economic collapse, bringing the most interconnected global economy the world has known to its knees. As country after country locked down to protect its people from the coronavirus, we're now facing, probably for the first time in history, a truly global event that has touched and altered lives around the world, as people everywhere share the experience of fear of a common threat. This globalization of fear and anxiety is without precedent, and in a way builds a common identity as global citizens. And I hope that throughout this session and with the great speakers that have agreed to come and share their experience and views of this crisis, we'll be able to touch on a topic that is probably the most important today, which is the issue of common goods for health. Where were we before COVID-19 hit early 2020? We were actually living through a period of remarkable progress on access to health services and on health. Over the past decades, this progress has been nothing but amazing, raising the hope that we will get to the great convergence in which all people in the world would enjoy long and healthy lives, and poor developing countries would actually join the experience of richer countries over the past century, in which child mortality, infectious disease had almost disappeared. Yet, collectively, we neglected substantial risks that were looming and which we too often ignored at the benefit of more immediate preoccupations, but forgetting that what we were seeing was not necessarily what was coming our way. Putting maybe too much faith into historical analysis of the past at the expense of scanning the horizon of future threats. And we find ourselves today with a pandemic that illuminates the fact that health systems are unable to manage and respond to pandemic and outbreaks, to the emergence of non-communicable disease that we find proves to be a major risk for the pandemic to increase its mortality toll. The risk of evolving disease, including all disease, but all disease with new problems, such as drug-resistant TB, or as we see also malaria recurring, or Zika becoming different from what it was before. And what is expecting us at around the corner is the large health impact of climate change and environmental degradation, which we see already in many aspects, including extreme weather events. It's time for collective action and global collective action. And here, when we talk about common goods for health, we talk about a well-known economics and public finance concept, which talks about population-based functions or interventions that only the collective arrangements can finance. Markets became incredibly globalized over the past 2 decades. Globalization delivered. It delivered in income growth, it delivered in poverty reduction, but it also created a new set of problems, inequalities. And it was not accompanied by a globalization of collective mechanisms that were ready to take the challenges of public goods and the challenges of large global market failures. So we define common goods for health as goods and services that have enormous impact on human health and welfare, and for which government intervention is required. Markets don't deliver on those. They are either public goods or they have large market failures. Next. So we're talking about 5 categories of functions and services that are, in a way, the step 0 of health system investments, and as such, the step 0 of universal health coverage, which are policy and coordination, taxes and subsidies, fiscal instruments, regulation and legislation, information analysis and communication, and population services, those large population programs such as immunization that require, because of many market failures and externalities, an important intervention of the state. And these are really those this fundamental base, the feet of health systems that we need to invest in as a step zero towards universal health coverage, which itself we increasingly know, because of more and more evidence we get from decades of investment in modern states, that universal health coverage delivers not only on equitable health outcomes and well-being, but also on inclusive economic growth and employment, and on global public health security and resilient societies. Only to watch the news today, we see the importance of universal health coverage as an equity building approach, as a social contract, and the importance of ensuring access to health services through some common financing mechanism that allows to respond to a health crisis. Next. And as we were enjoying these major improvements in health over the past decades, with the grand convergence and the decline in child mortality, maternal mortality, many different communicable diseases, we saw at the same time that spending on health actually increased in the world. As countries get richer, people want more health. The moment people get out of poverty, they start spending on health for their children, for their families, for themselves. And we see private markets, private providers emerge. What we see also over the past 2 decades is a progressive shift of the financing of health. Not only more money, spending on health globally in developing countries increased by a factor 6 between 2000 and 2017, multiplying domestic spending on health 6-fold. But it also became more public, which means that as societies get richer, they tend to think that collective arrangements are better to fund health and move away from private financing and out-of-pocket spending towards designing the kind of institutions that allow better risk sharing and better, more efficient financing of health. And when we look at what is happening in terms of common goods for health, interestingly or lamentably, as we see the increase in public spending over these 2 or 3 past decades, we see at the same time that public health functions, public goods and common goods have been largely neglected. We have reports from many countries of slowing or declining investments in public health institutions. In the public debate, there are questions about the misalignment of funding with need of Public Health England, Santé Publique France, or US CDC. And yet, what research and country experience show is the common goods for health and generally emergency and preparedness response management are very affordable. We're talking about a very low cost as compared to the cost of disaster. And if anything, the COVID-19 epidemic has confirmed that. The cost of preparedness is much lower than the cost of response and is vastly lower than the cost of the economic crisis and the hit that the economy is likely to take, with now the IMF and OECD projections talking about a decline of 6% of global GDP. When we talk about common goods for health, we talk about 0.4% of global GDP. We're talking about less than 4% of spending on health today. So why government should invest in common goods for health? Because the economic and social values of common good for health are large, and the costs are tiny compared to the cost of not acting. We know that markets will not deliver. It shows. If anything, we never had such vibrant market-based policies in the world and globally. Yet, COVID-19 happened. Government financing and action are needed. Markets and societies cannot play, civil society cannot play the critical common goods for health roles because they are in need of collective action. There are also investments that strengthen national security, individual and community health and well-being. Again, the COVID-19 pandemic today is painfully reminding us of that.
Okay, thank you very much, Agnes.
Thank you very much.
Sobering messages, but I think that we'll have some other potentially more positive messages coming out of some of the country experiences as well. But we'll go to Jesse now to speak about some of the work that he's done on this topic. Thanks.
Great, thank you, Susan, and thank you, Agnes, for those comments. Welcome, everyone. Good morning here in the US, good afternoon, good evening elsewhere. Look, Agnes is sketching out some of the very common observations about common goods or public goods and collective action problems. It's that there are all these things that you could be personal, you might be societal, that you know you should do, but action is hard. Governments they usually want to, in some sense, take action on common goods. Protect the air, protect water, protect natural resources, but it's really, really hard. And so I'm gonna explain to you some of the difficulties about why doing what seems so obvious to those of us here, and I'm assuming that everyone gathered here has some interest in health or medicine and public health and things like that. This is the core reason we have a World Health Organization. It's the exact topic around which the first of the sanitary conferences was gathered in 1850. So we're talking about a problem that people around the world have tried to solve for a long time, but it's very hard. So here on my slide, you can see I've given you two axes to think about. One is individual choices. That's things that a person would decide by themselves versus collective decisions. And then things that are personally engaging versus broadly politically salient. So down there in that lower left corner of personal and individual, that's where private market transactions start. It's like a deal for mutual benefit. Let's assume the market is benevolent for the moment. Just say, you're selling lemonade or you're selling sneakers or whatever it might be. You need one customer, and individually people opt into the bargain that you're making, and as a market participant you adjust your products, and hopefully things go well. But you can have, and almost all companies do this, they have a great business that has really nothing to do with collective decisions, and if you like a flavor that I don't like, it doesn't matter to me, you buy what you want. That's the private market. But over in that top right corner is where collective action lives. And that's where government policies are. Government policies are binding on everyone. So if it's an entitlement, a set aside, a tax policy, anything, speed limits, roads investments, schools, whatever the government wants to do, it has some effect on everybody. And I'm sure that all of you in your personal experience, maybe professional experience as well, will have noticed that a government will say something that you think is reasonable, and immediately there's an enormous outcry from many different groups. If it's a reform in health, well, physicians will speak up, providers will speak up, hospitals will come out, there will be patient groups, and before you can do anything, you have a massive debate. And this is just because the dynamics are really different. If you look in a little bit more detail down in that lower left to think about what private engagement and individual choice mean, it's that private benefit is simple to calculate. Sometimes this is said as like greed is good, to quote Carl Icahn. Response is to an immediate issue, like you're thirsty, so you buy lemonade. It responds to very short-term incentives. The market is very nimble. And then beneficiary and advocacy groups, they organize organically around personal and economic interest. And they become much more powerful. So you start down there, you can start at a very small scale, and quickly you can gain influence and momentum because you have a self-organizing community. And compare that to what needs to happen over there in the upper right square, which is that everything is just a lot more difficult. The public benefit is hard to calculate. I'm sure many of you are in cities or have lived in places where clean air is a problem or where traffic congestion may be a problem. These are classic common goods. And they're like everybody's business, everybody's problem, but nobody's responsible, nobody's accountable. It's really just hard to get going. And despite the need for action and the difficulty of the action, even then it's hard to calculate the exact benefit. You know, how much better off would you be if X happened? Can you really even foresee X? You know, I think this sort of diffuse nature of the problems, it frustrates the simple solutions that you think about immediately, and it makes them hard to test because they're defined by these really broad things. It requires everyone to move at once, and that presents difficulties for forecasting. It opens up for a lot of debate about what exact solutions are. And if you combine that with the general disinclination of all of humanity to prepare, you have a very difficult space. For those of you who are clinicians, you can think of a patient encounter. And if you've been a patient, you can understand this. But, you know, you say to one person, okay, you know, you really should change your diet or quit smoking or get some more exercise. And on the individual level, that kind of prevention is extremely difficult, even though you know the benefits, you know who would benefit, that's you personally, but you know, nobody really likes to prepare. And societies are that problem multiplied by all of its members. So usually the long-term benefits, the vastly superior investment case, the many benefits that would accrue, they sort of seem misty or somehow out of reach because it requires rethinking the organization of society in some way, and it requires you to overcome concentrated economic interests. So that's one of the problems in collective action. It's that, let's say you want to protect the environment in some way, let's say water. Well, immediately the industries that use a lot of water will organize against you, whereas the beneficiaries, they tend to have a much less certain view on either the feasibility of the intervention or the benefits they would have. So this is the setup of, this is why a great idea, that is investing in collective action problems, investing in common goods, this is why it's hard. Like, you know, you should in many ways. Populations do, individuals do, governments do, but it's really, really difficult to achieve unanimous or collective decisions on an issue that's politically salient. So one of the things that Agnes and Sumi Krishnamurthy Reddy and I did was we wrote a paper that tried to investigate the reasons. I'm gonna put that in the chat right now. There's a link to our paper if you want to see it. And just to give you our top level findings, we found that there were 5 reasons in historical cases that governments were able to move toward collective action. And the first was that there was political salience, contextual salience around the particular problem that they were working on. So in today's terms, if you're thinking about disease surveillance, many people are paying attention. The context is aligned with that objective. Number 2 is that the government in each case aligned with at least one outside group. So that could be a professional group of interested specialists. It could be an advocacy group for for victims, it might be an environmental group, but at least one outside activist group had to collaborate with the government to produce change. Number three was that in all of our successful cases, there was a clear strategy and a well-identified solution. We found a very diverse pattern of the initiation of collective action. It could start in the government, it could start in civil society, it could start in a lot of different places. So we remain agnostic. It can start anywhere, but you have to have some kind of collaboration to make collective action possible. And the last one is that the timing of action was quite sensitive. First, each case that we investigated had long preparation, so at least 25 or 30 years of advocacy by certain groups, by specialists preparing solutions, by professionals looking for evidence. It's a sort of a long run-up, and you could find that heritage underlies many of our problems in common goods. So it doesn't mean that any action is 25 years from today. It just means that you need a lot of preparation and organization. So this brings you to think probably about COVID and the COVID era, and you'll say, look, some countries took the political salience of a pandemic, very hard to deny, and they made collective decisions. We will hear from some of those countries today. Other countries, and the UK will be one of them. I can see my friend and colleague Peter Smith has joined us, so he will perhaps have something to say about that along with other people observing the UK. And here in the US, we lead the world in dysfunction. And that is because you have this political salience, which is all the way on the right of that graph, but you're stuck in the individual choice. It means people don't agree. They don't want to coordinate. They can't agree on whether you want to wear a mask or not. They politicize the difference between those, and you have societal breakdown. On either axis, you can have all the resources you want, which is true here in the US. There's lots of resources. It's not a money problem, but the ability to coordinate around them is a major stumbling block that many countries have handled far better than some of the richest ones. So I'm going to end with those thoughts. I've put the paper I mentioned in the chat box. I'm happy to take questions live or in the chat or later on if you want to email me. My name is unique enough that a quick Google will identify me and my contacts. So I will look forward to the discussion. And thanks again, Susan and Alex, for facilitating.
Thanks so much, Jesse and Agnès. So in the interest of time, I'd like to move on to the country panel. So then we include one big chunk for the discussion, if that's okay. And I think that there are a couple of questions in the Q&A box as well as the chat function that can be answered as well. So with that, I'm going to move to our esteemed panel of speakers. So first, I'd like to introduce Dr. EMAVWODUA, who's the Director of Policy, Planning, Monitoring, and Evaluation within the Ministry of Health of Ghana. So he'll speak first, but all three speakers will be looking at this question of what have been the governance-related challenges to investing in these and implementing these common goods for health, and then how or what are the mechanisms, what are the strategies that have been used, what are the contexts that have enabled actually making positive progress towards implementing these common goods for health. So with that, I'll turn it to Dr. Odame. Thank you. I see his screen. I'm not sure, Dr. Odame, are you there? If not, he might have gotten called away. So maybe we'll start with Dr. Palitha Abekun, who is the president of the Sri Lankan Medical Association and also chairman of the National Authority on Alcohol and Tobacco, to speak about the Sri Lanka experience, which is very long and interesting. Thank you.
Good morning, good afternoon, good evening. Thank you, Susan. It is a privilege for me also to share a few thoughts from Sri Lanka at this webinar. And of course, my thanks go to Susan and Alex for giving me this opportunity. Sri Lanka has been considering health as a basic human right for a number of decades. And reflecting this priority, the government of Sri Lanka dedicates government tax revenues to ensure equitable access to all people in the country, health care being free at the point of delivery, regardless of whether one is a citizen of the country or not. Also, Sri Lanka believes that common goods for health serve as a foundation for our health security. We also believe that the provision of common goods as an essential element for reaching sustainable development goals, and that they are also imperative for mitigating poverty and poverty reduction. Delivering common goods for health, we believe, requires intense community engagement and, of course, a strong political commitment. Financing common goods has been a priority here. Today's discussion is very timely for us when we consider the rapid changes which are sweeping across the world today, triggered by the pandemic, and which is having a profound impact on our lives, and certainly here in Sri Lanka. Very quickly, I will share with you how Sri Lanka has been faring thus far, and how did investments in common goods help us in this battle.
Dr. Abekun? The connection might have been lost. We'll give 1 minute to see if he can log back on. Okay. So I think we're actually at an inflection point. So we've now heard the background on Sri Lanka's system, and Dr. Abekun was about to speak about the current response. So maybe Sunman, if it's okay with you, if we can turn to you to speak about the Korea experience.
Okay, why not?
We're adapting. We're showing ourselves to be flexible.
Okay, good, no problem. Thank you. Well, this regarding the underinvestment, I would say this is kind of chronic underinvestment in the common goods for health. You know, this is a typical case of those collective action dilemma, things like that. But if we focus, if we discuss this CGH in the context of public health or investment in the preparedness for the current type of COVID-19, I think there are a lot of political issues here as well. Because if we do a economic analysis or cost-benefit analysis of the public health interventions or preparedness for a serious epidemic or infectious disease, I'm sure in most cases the result is always positive. I mean, it is cost beneficial, so we should invest in the preparedness and intervention. But even if the economic calculus or rational calculus tells us that we should invest, but what kind of investment is there for the politicians or policymakers? Because for them, the majority of the cost of investment occurs in the short term, whereas most of the benefits, they occur in the longer term or medium term or longer term. So for the whole entire time framework, it is cost beneficial. But for the politicians, at least for their tenure, when they are in their office with that shorter time framework, maybe cost is greater than the benefits. And also cost is more tangible, whereas benefits of investment is more intangible, because most of the benefits of this preparedness or investment are in the form of, say, avoid the serious negative consequences. But people cannot see those avoidance of those blah blah blah. So I only think that the politicians or policymakers do not have very strong political incentive to invest in this public health or preparedness. In the case of Korea, we are lucky that we had, I would say, a reasonable degree of preparedness for a pandemic like COVID. That's one of the factors behind the so far successful response to COVID-19 in Korea. Then how come Korea was able to invest in this CGH in the preparedness? Because we had a very serious or painful or costly experience of MERS. It's a Middle East respiratory syndrome about 5 years ago. So before MERS, Korean government did not have any, I would say it's very, did not have enough knowledge and preparedness for a serious infectious disease. So when MERS kind of came to Korea, we have many casualties, no contact tracing, little preparations in epidemiology. So after the MERS, the government realized that how important it is to have a preparedness. So after that, government strengthened the Center for Disease Control, and government revised the infectious disease law such that we introduced only at that time, only after MERS, Korea introduced very aggressive contact tracing and introduced the disclosure of contact tracing information to the general public, and also revised the law to coordinate the central and versus local government. Before MERS, our preparedness level was very low. So in that sense, I think this current COVID-19 experience, although it's quite painful, but I'm sure that this COVID-19 experience after this will give a good kind of incentives or felt need for many governments around the world to invest in the preparedness or overall CGH. But that is the preparedness side. But in that sense, it's a bit paradoxical stories that for this, I think the Korean government during this response to the COVID-19, people were too much concerned about this COVID-19, I think. So I'm a little bit worried. I started to be worried about the potential indirect impact of this COVID-19. Because although Korea did not have a lockdown, but we had a relatively strong, social distancing. Many people, most of the public voluntarily participated in the social distancing. So old people, vulnerable population, and people with existing disease, they're reluctant to use healthcare. So I'm a bit worried about the delay in the diagnosis and the medical care utilization related with this serious disease. I think this is kind of unintended consequences of paying too much attention to COVID-19. So I'm a bit worried about the potential excess mortalities from the patient with non-COVID-19 disease issues. I think I can give more comments after, in the next round. Over. Thank you.
Thank you very much, Sunman. So really points around political salience. And so then the question is, what happens to the other issues that are maybe not quite as salient in this particular moment? So Dr. Odame is here, and I see that Dr. Abe-kun is back. If that's okay, maybe we'll turn to Dr. Odame, and then we'll close with the current status on Sri Lanka.
Sure. I'm so sorry, my internet failed suddenly. I'm so sorry.
Of course. We expect these things to happen.
Yeah, I'm very sorry.
Okay.
Please.
Great, thank you so much. Okay, Dr. Odame, and then we'll go back to Dr. Abe-kun. Thank you.
Okay, so thank you so much, Susan, for the opportunity. And I think the question is very clear in terms of what we are talking about here, common goods for health and what the opportunities hold for countries. I think it's quite succinct from what Agnes said from the beginning, are the 5 areas that constitute the common goods for health: the policy and coordination, the taxes and subsidies, regulation and legislation, the information analysis and communications, and also the population services that should happen. These are areas that it's coming very handy with the coronavirus pandemic that we go through as a country in Ghana. Clearly, if we are going to make any headway around those issues, clear governance challenges has come up to us as a country. And one of the areas we've seen when it comes to common goods for health is our current landscape architecture in terms of how we even coordinate our resources from the Ministry of Finance level. Most of our budget hearings are siloed single ministry budget hearings. But the lesson we are hearing in COVID is that it can only be overcome with multi-sectoral actions. Currently in Ghana, our COVID coordination is being led by His Excellency the President with an inter-ministerial coordination committee meeting daily to discuss how we fund COVID. It's coming increasingly clear to us that if we are able to fund the common goods for health, we might need the same multi-sectoral approach in our budget coordination to be able to fund these 5 areas: the governance, the policy and coordination, the taxes and subsidies, the regulation and legislation, and information analysis and communication. So this clearly might require a shift in our current budget hearing to a more multi-sectoral hearing, and also looking at these areas clearly if we have to make any headway. The fact of the matter is we cannot do anything now than to abide by this technique. But this is not going to be our last pandemic of a sort, and this is not going to end it yet. So this is what we've learned, that we need to coordinate our funding sources very clearly with a different design of our financing landscape, a different design of our sector. And then we ask ourselves the question, where Ministry of Health is placed? What business are we in? Is it health or healthcare? Because it is health, then even how Ministry of Health are placed and the kind of personnel that work in Ministry of Health, we'll all have to rethink around it if we have to bring on board the common goods for health and be able to achieve it. The reality is that without bringing on board common goods for health and addressing it as such, the world cannot overcome major pandemics as it evolves. Over.
Great, thank you, Dr. Odame. Speaking a bit of my language on the budget redesign questions, and so really getting into more of the mechanics associated with some of these political shifts as well. So Dr. Abe-kun, we can go back to you. We got a brief introduction to the background on Sri Lanka's health system. And so now I think you're about to start to speak about the current situation in Sri Lanka in relation to COVID.
Yes, very quickly. Please, forgive me for the lapse. I mean, I could not help it. The internet broke down suddenly. Thank you. The first case in Sri Lanka was on January 27th, when we had a Chinese tourist from Hubei province who was diagnosed as having the infection. Then on 3rd March, she was treated here and she went back to her home 2 weeks later. Then on 3rd March, we had our first case among Sri Lankans, contracted from a group of Italian tourists who were touring Sri Lanka. And since then, most of the cases were not due to, none of them are due to real endemic transmission. Later, we had new infections from Sri Lankan returnees from the Middle East and India and from some other places. The first local case onwards, the government took very serious measures. We had very good leadership, locked down most of the country for about 4 weeks, did a lot of tracking, tracing likely contacts and quarantining them, and of course treating the few who needed treatment. All done in a very organized way because of the history we had with regard to the epidemics and disaster management. The excellent public health system, which we are very proud of, particularly the disease surveillance system and the well-trained epidemiologists we have, backed by the virologists, played their part very well. The health staff and the defense services staff, who have been very well trained in disaster management for the last almost 20 years, and in intelligence gathering, work closely with each other, especially for tracking and tracing. To give an indication, as of end of March, we had about 15,000 persons who were traced as contacts and either sent into quarantine or sent into self-quarantine. About 4,000 of them were in quarantine centers, and others were in self-quarantine. We had 2 clusters at the time. One was among the group of Navy sailors in a camp, and other was among the expatriate returnees who were both of which were contained quite quickly. I want to just share with you a small note I received from one of our young epidemiologists working in the field. I received this about 3 days ago. He says, I quote, "Prevention is known to be better than cure, and COVID-19 pandemic has forced our communities to see it's true. The Ministry of Health and the team, the grassroots level institutions that strives for prevention of diseases, the COVID-19 outbreak changed our daily routines drastically. Each development revised our roles and schedules. The confirmed case in the area required a team visit for a quick contact tracing, quarantine and containment. In these trying times, we work very closely as one team with the local authorities, the police, the tri-forces and the community. Technology is our ally. A list of contacts of confirmed cases arrives by email each morning from the regional epidemiologists. Faxes of lists of returnees from abroad pour in from the police stations. Information is shared widely. It is tough, but we want to do it, and we are managing okay so far." Now, one thing I need to say in regard to this is that repeatedly I've been saying this, that our population and the community was somehow prepared to take the restrictions during the lockdown period. And in fact, they have been not making any sort of noise with regard to not having to celebrate 2 of the biggest festivals in Sri Lanka, one in May and one in June. There have been a few lapses, mainly due to the negative consequences of people becoming complacent, and we had a very few infections due to this. And there was also a certain amount of fear and suspicion being spread, and these have to be handled very sensitively. Thus, our numbers so far of the infected have been reasonably manageable and not overwhelming the capacity of the health system. We have had a total of now, as of yesterday, we had a total of 2,500 cases from the beginning, out of whom about 1,900 or nearly 2,000 have gone home cured, and we have had 11 deaths during these 4 months, and we didn't have a death in the last 6 weeks. Now, of course, we saw from 3-4 days ago, possibly the rise of a second wave, starting from an set of infections which came from returnees from the Middle East. And this went into a camp, in a camp. And of course, since it is in a camp, I think it is manageable and the government is handling it quite well. I think they're confident that they'll do it okay. I will not speak on the economic effects, which are of course going to be quite significant for a country like Sri Lanka, which depends on the money coming from our expatriate workers as well as from tourism. Just one more point and I'm going to stop. Just last week, Sri Lanka was certified as having eliminated measles and rubella, along with Maldives. Only 2 countries in the Southeast Asian region which have managed to do this. This is after we have eradicated a number of earlier diseases earlier, or eliminated many other diseases. And all this, I think, is because it's not a surprise for us, because we have strengthened our health system elements in the last 30, 40 years very, very well, I believe. And immunization has been one of our strongest points. Along with that, disease surveillance has been very, very well established in Sri Lanka. And I will not, I want to relate some of these, and I'll stop by saying that, by emphasizing that most of the successes that Sri Lanka has been achieving has been because I think the government has repeatedly, the governments have been spending reasonable amount of investments on what we call the common goods for health in Sri Lanka. Last 5 years particularly so, and this started about 20 years ago. So I will stop there. I will respond if there are any queries with regard to what we have in Sri Lanka right now. Thank you very much, Susan. Thank you very much.
Okay, thank you very much, everyone. I think we're certainly hearing about the long road to establishing and investing in these common goods for health, and also the importance of the community and really grassroots, getting down to the real health worker, community health worker level in Sri Lanka. And also, yes, I did read about measles and rubella, and I know Dr. Abe-kun, you've been very involved in that, so congratulations on that accomplishment from a policy side. So now I'd like to stop and have questions, and we'll start by, we're happy to welcome questions from the floor. Ben Rufi-Lee is managing that function from our side. So if anybody would like to, and I know that there's been some active discussions in the chat box, particularly from people who sit in potentially politically fractious places that we're seeing that intersection between politics and public health and how complicated that dynamic is. So please, if anybody would like to ask a question to the panelists, and if you have someone in particular that you'd like to answer the question, we ask that you note that in your question as well. Thank you. And comments are also welcome. So while people are formulating their ideas, and because I'm impatient, I'll start by, I think there were some questions at the beginning related to the role of the private sector, both in relation to healthcare delivery, but also in relation to this dynamic around collective action and governance related considerations. So I'll raise that if the panelists have any reflections on the role of the private sector, particularly in Ghana, Sri Lanka, and in Korea as part of the response.
Shall I make one comment about Sri Lanka?
Please.
Yeah, in the beginning, the private sector was not directly involved with with responding to the epidemic, but later, when testing became big and widespread, and the capacity of the government was getting tested, the private sector was also requested to join in and help with the testing. So private sector has been mainly concerned with increasing the capacity for testing in Sri Lanka for the last one month or so. With regard to treatment management, no, the government sector is still very well under control. We have enough capacity in the government sector. Of course, if the numbers increase unexpectedly, or we hope it won't, then of course the private sector might have to. They do not. they participate in the treatment. Anyone found to be positive in the testing is sent to a government facility which are dedicated. There are a number of facilities around the country which are dedicated with trained doctors and nurses to manage those. So Sri Lanka private sector's role is so far limited only to testing. Thank you. Thank you.
Wonderful, thank you. So I'd like to turn to Haitham Noaman, who
Yes, thank you, Doctor. I am Professor Dr. Haitham Noaman, consultant of internal medicine and infectious disease from Baghdad, Iraq. Thank you for this opportunity to take question. Excuse me, do you hear me?
Yes, we hear you well.
Thank you. We are facing in a big storm of COVID-19 now in Baghdad and in Iraq, but it is most common in Iraq. It is overcome the health sector, the governorate health sector, and the private sector. And then the cases is too much, but we need action which decrease morbidity and mortality in our community. So I would raise this point, please, in this conference, that we made an electronic clinic. This electronic clinic, we made a WhatsApp group with patients. We made a video chatting with patients, and these video chatting with patients, we advise them for investigation. We learn them how to manage these cases. This I mean for mild, moderate cases, not for severe or life-threatening condition. These two last subjects of severe and life-threatening condition, we admit them to hospital. But for moderate and mild cases, we manage them by electronic clinic because we are facing large number of cases in the private sector and in government sector. We advise them to do investigations. They did the investigations. We advise them for treatment and to follow up, and we learn them how to follow up these. We made with many consultants and professors and assistant professors in this field. We will publish this paper. We found that decreased level of morbidity and very negligible rate of mortality. This is an experiment whom we tried in Iraq. Also, I have a question, please. As there are many professors and consultants and specialists from many countries, we face a storm of COVID-19 in many countries of the world. My question, how much we get herd immunity in the community from December to 2019 till this day after exposure of that large number? Thank you very much.
Okay, thank you very much. Jesse, I think that question was for you.
Sorry, I was answering a different question in the
Yes, there's a very active discussion in the chat function, which is wonderful, but I'd also, speaking as someone who also can't monitor the chat function that well, that please feel free to bring the discussion into plenary as well.
Yeah, I'd be happy to respond. Can you give me a 3-second version of that question?
Sure. Haitham, do you want to just repeat the question quickly for this question of how do we get from December 2019 to today? And I think there were some really interesting reflections about the shift in the delivery model in Iraq in terms of how to reduce morbidity and probably some lessons for other countries as well.
Rapidly, we made an electronic clinic, and this electronic clinic succeeds in our community to decrease mortality and morbidity and decrease exposure of us to patients, because there is many specialists and doctors infected, and some of them fortunately died. And this experiment is applied in other countries whom exposed to COVID-19? Another question, what's the results of herd immunity from the, December 2019 till now? Thank you.
Okay, so a bit more of a biomedical question, which is interesting, but I think maybe we'll table that for other discussion. If perhaps if people have medical expertise, they can lend that answer in the chat box. But I think there was a question about, I think that there's been some reflections in the chat box about this question of what happens at the national level about politically fractious or fragmented discussions that maybe aren't aligning with public health motives. And there was a question about what types of civic engagement. So in the absence of that top level leadership, from your experiences either in countries or from those people who've been studying this topic, what are potential channels to think about in terms of mobilizing collective action around these common goods for health? As we said, we're a bit preaching to the converted here in terms of their importance. Thank you. Sunman, I don't know if you wanted to speak, to answer the question first.
I don't have a very good answer to that one, because I still think that for this common goods, I understand now that you have a slightly different definition for common goods versus public goods, but whichever. But still, I think that it's very important for the government to invest something. But when the government, for example, as I mentioned in my very short comments, the politician may not have a very strong political motive, and in that case, I think there should be a very important role for the civil societies and NGOs, and from the bottom up, and push the government to invest. But the other question, I mean, the kind of question I would raise is that we are talking a lot on government or governance, but okay, in the investment, in the preparedness, I think especially in the public health or COVID-19 cases, a bit tensions between central versus local government. Then even in the case of investments in the CGH, what is the role or sharing the role between central and local government? That is another very important governance question. So I also want to hear from other participants on this issue on central versus local government in the investment for CGA on CGA over.
Thank you, Sunman. So Dr. Abe-kun and Dr. Adame, I don't know if he's there. I know he's in the Ministry of Health building at the moment, and so likely gets called away. But this issue of the dynamic between the center and the state, it comes up a lot in relation to common goods for health, and how that if you don't need just action at the national level, but you really need that implementation capacity and potentially financial resources from local and subnational levels. If you have experience in that dynamic from Sri Lanka.
I cannot hear you.
Yeah, Dr. Abe-kun, you're muted.
Oh, the line was not very good. Please, you can repeat it. I'm not hearing you.
Yeah, sorry. Okay. The Sri Lankan situation is like this. We have a central government and we have what are called provincial governments. And there are some overlapping functions, what are called concurrent functions. And health is devolved, part of health is devolved, but part of health is concurrent. For example, epidemiology, surveillance, disaster management are central or concurrent functions. And the lower level or the private healthcare level institutions, etc., are managed by the provinces. And the way they share the budget is also according to a formula, but of course, most of the money is still with the central government. So there is no real tension. There is debate that the provinces are not getting enough funding from the central government, but it's a fairly healthy debate, but it has not caused any serious issues as far as I have learned, I have seen. The two seem to be working quite okay, I think. And in the current epidemic, of course, the central government played the main role, and the provincial governments or the provincial staff who are on the field, they did most of the work on the guidance and advice from the center. So there was reasonable harmony and reasonable coordination there. And of course, our ministers of health, they have meetings every month, so there is a lot of mixing and discussion, but no real tension as such. With health, there is no tension. With other straight political issues, there are a lot of tension. With health itself, not much.
Mm-hmm. Great. Thank you. Yeah, maybe a difference between a more centralized government and financing system as compared to some of the other countries that have been discussed in the chat function, South Africa and the United States as well. Dr. Adame, did you have any reflections on that particular question?
So, Susan, thank you so much. I think what is coming up strongly is the fact that we can't pursue this common goods for health if we really don't look at even our budget architecture. And these are quite hard questions that may need to be had at higher levels of government. That moving forward, common goods for health should be high on our agenda if we are to achieve UAC. And like we are saying, it's a zero step to achieving our universal health coverage roadmap, as it were. So we need to begin some conversations, I think, across countries and also within countries. Clearly, the lesson we've learned from COVID is that we are in health and not healthcare. And I think that difference is clear. And that in managing COVID, we've had to bring on board the security agencies who will enforce regulations of wearing of face masks. Ghana has just passed a law, a EI, to ensure compulsory wearing of face masks. And that has to be enforced by the military and the police, after working with the Ministry of Interior. But these things are able to be enhanced because the coordination of COVID is at the presidential level. So moving forward, health really will have to be looked at as a major thing if we are to move countries forward. The lesson we've learned in Ghana, that our GDP growth for 2020, that was about 6.5%, had to be recalibrated to about 1.5% because of COVID. So clearly, the impact on health on socioeconomic growth is clear and cannot be debated. That debate is just not tenable. So moving health into a higher conversation and higher discussion becomes key. But the question then comes back to us. You see, we revolved our both ministries of health around the world around healthcare professionals, looking purely at healthcare. And that's why I keep on talking about architecture. Because we may have to now look at even ministries of health that have geographers, ministries of health that will have some archaeologists, some historians. So health will really be appreciated from the different dynamics that will have to play. But the truth that as we include more and more in the animal ecosystem, issues of pandemics and all this will keep on recurring. But it's our ability to change that fundamental architecture, one of our financial, Ministry of Finance system, the budgeteering system, two of our healthcare systems, and then three, leadership. Because effective results will be good ideas, but also effective implementation. How do we assure those effective implementations going forward if we are to make progress on the common goods for health? And I think this thing becomes very key in our UAC mapping as we move forward. Over, Susan.
Great, thank you. Yeah, I know this issue of how to realign the financing systems and budgeting systems to enable these common goods for health. I think that's both a sectoral issue within the health sector, but clearly also a government-wide issue. And so before we turn to Uti to speak about the global common goods, I just wanted to give God leave. She's been active in the chat function. If you wanted to share any of your reflections before we move on to that topic. I think Ben might have to unmute you.
I can unmute myself. Can you hear me?
Yes.
All right, great colleagues. Thanks very much. Absolutely exciting topic. And I personally have felt for a long time that this is the ground zero. but a lot of work is still to be done. And the 2 points that I'm very interested in personally is how do we really move on this fragmentation or this split between the collective thinking and the more personal, individualized thinking? Because in the political economies of many countries, I think this is a huge topic. And the second thing was brought up just now by Jo Ankra. There are so many structures standing in the way still of proper financing common goods for health. So there is a political economic angle that I think would be very important to take on and also take away from this webinar, because we're not doing this for no good reason. We actually want to help move and help create spaces as our Building the Reset campaign. So thinking deeper about the political economic possibilities of creating space for these common goods of health, and creating pragmatically, but that is still also a hard job, the answer to Joe's question about what do you do with budget structures at the moment, because that is still the level that we have to fight at, I think, in countries. And this is the time, I assume, to try to do that, because all countries are at a deeper level reassessing their structures. So I think we should start that conversation at the right places. And I would really love and welcome comments from all the esteemed panelists, because they have a lot of experience already there. But what can we do to move this agenda? So thanks very much.
Thank you, Godlev. So I'd like to give the opportunity so I see Dr. Abed-Kun one last comment, and then we'll move on to the next speaker. Thank you.
I'm just trying to make a response to what I just heard. Is
Please.
it okay?
Please, yeah. Yes.
Two things. I mean, this is also from a Sri Lankan perspective, Susan. One is that somehow at the country level, Ministry of Health and the other related ministry level, the terms common goods for health are not yet very common language. Occasionally we hear public goods, but common goods are not heard most of the time in our discussions. So maybe, since we know the difference, since we know the significance, maybe it is good if we can share this idea and share this concept a little more widely with the ministries of health and the related ministries in the health sector. That might be useful, number one. Secondly, very quickly, it might also help us in terms of advocacy and also in terms of generating evidence, if we can find some way of determining, say, those countries which have invested reasonably well in common goods. How did they fare? I mean, how did that help them in meeting the epidemic and its aftermath? It might be useful. That might generate some useful evidence for us if you can think of them. Thank you. Thank you. That's just a thought.
So, Susan, I think one very short comment. I think this issue of investment in the CGH, there are other very important related factors, a bigger picture, like broad level of societal equity, social trust. They're all interrelated. I mean, if the society is more equitable, then there are higher level of social capital, social trust, and people are more willing to invest in, the public invest in the CGH or public goods for that area. Whereas where people are, I mean, the society is a higher level of equity, and the social capital level is low, and the overall societal level willingness to invest or publicly invest in the CGH will be very low. So I think a bigger picture of the political economy or aspects of all of it over.
Yes, thank you for that. I think both speakers have clearly set a very strong research agenda for those of us that work in the research field as well, and understanding and really trying to understand these typologies as well. So I now will move on, and unless Dr. Odama, if you have any closing remarks. Okay, I'll move on to Dr. Uti Kuznanimi. She's a senior level expert with the Finnish Ministry of Social Affairs and Health, and has been very involved in the Common Goods for Health agenda. And just to say, I also want to respond a little bit on the terminology. It's true, I know that there's been an active chat function, but it is a new concept and a new terminology and a bit more expansive than public goods. And so we welcome the discussion and that idea as well. But just to say that we've been focused a lot on the domestic level common goods for health. But as part of the special issue that Alex shared in the chat function is that there's also a very large global agenda related to global common goods for health that don't necessarily sit within any one country, and they might be regional or global level. And Uti is very involved in that from the Finnish side, and so we look forward to her reflections on the governance related challenges of trying to move forward a global common good for health. Thank you.
Thank you. Over the last century, most pandemics have been caused by influenza viruses, for which we have tested methods for the production of vaccines. However, as there has been no global coordination mechanism for allocation, we have still seen inequitable access to vaccines. Developing countries have usually had to wait behind the high-income countries. The Ebola epidemic in West Africa was a wake-up call in many ways. With global trade and travel, an obscure disease was threatening the world. There was no vaccine and there was no effective cure. In a short span of time, over 11,000 people died, and the economies and healthcare systems were devastated in the affected countries. This led to several developments. Work began to develop a vaccine for Ebola, and finally, with the Ebola outbreak in DRC, 2 vaccines were introduced last year. But the outbreaks of MERS and Zika demonstrated that the threat to global health security could come from any source. Significantly, the plan of action for the WHO R&D blueprint called in 2016 for preparedness in the case of a disease X. This issue has been also highlighted by the Global Preparedness Monitoring Board. CEPI was launched at Davos in 2017 with the recognition that a coordinated international and intergovernmental plan was needed to develop and deploy new vaccines to prevent future epidemics. CEPI has a portfolio for the development of vaccines for agreed neglected diseases, including Ebola, MERS, and disease X. The principle of working on common goods for health is central to CEPI and its investors. With COVID-19, we are again facing the situation that there is no vaccine or cure for a new pandemic disease. The race for development of vaccines is happening at an unprecedented speed and scale. The side effect is that countries are being lured into a bidding war against each other for key positions at high cost and high risk of failure of the different vaccine candidates. Many political leaders have underlined that COVID-19 tools should be equitably available for all countries and that COVID-19 vaccines must be seen as global common goods for health. This was reaffirmed by the World Health Assembly in May. The effort to develop and deploy vaccines goes hand in hand with efforts to ensure equitable access to diagnostics and therapeutics and to enhance public health and social measures. To enable this goal, international organizations, leading countries, and other stakeholders have come together to develop a global solution in the format of the ACT Accelerator. Further, to minimize the loss of life and economic and social impact caused by COVID-19, every country in the world needs vaccines and needs them fast. The COVAX pillar is an end-to-end solution for the world that will address this need. It is led by Gavi and CEPI in collaboration with WHO. It aims to ensure that vaccines are developed as rapidly as possible, manufactured at scale in the right volumes, without compromising on safety, and delivered to those that need them most. For access to vaccines, the COVAX pillar provides a solution through portfolio diversification, pooling of financial and scientific resources, and economies of scale. The idea on one hand is that participating governments can hedge the risk on the success of vaccine candidates and receive an allocation of vaccines to 20% of their populations to be used for priority groups. On the other hand, governments with limited ability to finance bilateral procurement can be assured of early access to life-saving vaccines through the Gavi-led Advanced Market Commitment Mechanism supported by donors. CEPI has been financing vaccine candidate development and supporting scaling up and scaling out of manufacturing capacity. It has currently a portfolio of 9 vaccine candidates in various phases of testing and has concluded contracts for manufacturing of these vaccines for the benefit of the COVAX facility. There are also other collaborative efforts to securing access to vaccines, such as the EU partnership on COVID-19 vaccines, which is financed through the Common Emergency Support Instrument. How these different mechanisms will work together needs to be defined in the coming weeks and months. There is always a risk that countries with production capacity enact legislative measures to ban exports of vaccines, or that resource-rich countries buy up the production capacity. Vaccine nationalism is a real threat to the global efforts to end the pandemic. The new collaborative efforts aim to change the playing field and are asking countries and companies to work better together for the benefit of all. Thank you.
Thank you very much, Uti. I think it highlights some of the complex dynamics involved in moving forward the vaccination campaigns that we hear so much about. If you could prioritize, are there 1 or 2 key governance related challenges in terms of this international negotiations? What would you say?
Thank you. Well, these governance-related issues are being finalized over the summer, so it is still unclear how the COVAX mechanism will work, and we have many questions, and certainly we have questions as to the relationship between different initiatives. And we understand that the COVAX facility needs both high-income countries and low-income countries to join, so that the financing mechanism will work. So it is really something new, something untested, and we don't know what the problems will be. The market situation with the vaccines is challenging, to put in a mild word. We have several companies and other collaborations developing vaccines. We have no idea which one will be successful, which one will fail. And we need to ensure that the production is not limited to one place or one factory, that we have production capacity scaled out to different countries all over the globe so that we have enough of the vaccines. And then the additional element is related to the approval process and the testing and making sure that they are safe and efficient, and also that the logistics work, the questions related to cold chains and other mechanisms, and that vaccine campaigns are effective. There's a lot of anti-science movement, anti-vaccination movement around the world. How do we make sure that we vaccinate enough of the people so that we get true coverage and we can end the pandemic? I think these are some of the questions. WHO is working on allocation mechanisms and criteria, how to define the priority groups and how to allocate to different countries beyond the first phase of the 20%. Thank you.
Okay, thank you very much. So in the interest of time, I just wanted to, I know Agnes has a very hard stop to leave at 2:30. So I just wanted, Agnes, if you wanted to give any closing remarks or thoughts before we close the session. If she's online.
can I have a short comments?
Please, Sunman, yeah. Go
Yes,
ahead.
I think here there are two slightly different issues are mixed up a bit, because for this situation there are some domestic issues even within one country. There are lack of investment in some of the public health issues, things like that. Some part of this issue, but if you have a global view, there's a slightly different level of global governance issues, like vaccine development. That's a slightly different. I mean, they are interrelated to some extent, but not exactly the same. I mean, that's my view. Over.
Yeah, no, thank you for that. I think for me, I heard, I mean, the classic pooling question, and I think it's maybe perhaps two sides of a similar coin, but different issues for sure. So Agnès says that she is here and she's struggling with her screen. So I
can join.
Here she is. Okay.
Yes. Well, first, thanks to the panelists, which I think that this panel was amazing in terms of bringing about country experiences and also our experts who joined, and I think we more and more understand what we are up against, and this challenge of us as human beings being both individuals engaged in market transactions, but also members of societies and citizens of countries and citizens of the world engaged in collective action. And I really want to emphasize this particularly for this event, which is sponsored by the Health System Governance Collaborative and the community working on health system governance, that this is really at the heart of governance, because governance is about collective action. It's about building movements and constructing institutions that can handle those issues. And our modern societies are increasingly complex, but they also deal with increasingly global challenges because technology has made us more connected, physically and through new technologies, but also because population has increased, and the population pressure on planet resources is such that increasingly the problem of one person on one side of the planet is the same as the problem of another person on the other side. So the collective action problem becomes bigger. I mean, you can have a small collective action problem at community level, and then a bigger one at state level, a bigger one at nation level. And then you have this huge issue of global collective action. And when we talk about common goods, we talk about those. So it's bigger than public goods, which are, you know, completely non-excludable, non-shareable. These are really common functions. But it is about these very actions that require that collective movement. And we know that part of it is related to identity, that we are more likely to move together if we think we are part of a same body. And of course, globally, building a collective identity is much more challenging than building a collective identity at country level. Although we know that many countries are still struggling with building a common identity. And Jesse was referring to that, including the richest country in the world right now, the United States, is obviously struggling with common identity problems, with the pandemic revealing what is probably the most salient identity problem in the US, which is the identity linked to what is characterized there as race. And finally, I also want to respond to one question about the fact that budgets and modern states don't really recognize, health budgets don't really recognize common goods as such. And just to say that this is underway. We are right now working together with the World Bank and with the IMF to develop a guidance note for Treasury and for parliamentarians, and also for budget watchdog, to really put very squarely on the table the step zero of budgeting for health, the step zero of investment in health system, which are these common functions, these public health functions. Recognizing that for this to happen, and that goes back to the panel, this requires the social fabric to develop a healthy social contract that works for all. Thank you again, and thanks for fascinating discussion. Over.
Yeah, thank you very much. I think that was a very nice wrap up. Unfortunately, Bill Savadoff couldn't join us because he had a last minute meeting come up. But I also want to just echo my thanks to all the panelists, the speakers, the participants, the active audience engagement. I think for me, what is striking about the chat function is that many of the experiences it's very personal. It's a technical issue about common goods for health, but I think for people who are living in countries that, or potentially like myself who have family in countries that there isn't that action happening, we feel it very deeply and we feel the effects of that. And so from a governance side, let's hope that political salience really moves action forward. So thank you all. I urge you to sign up for if possible, the webinars on July 21st and 26th, and to become engaged with the governance reset, because I think it's really exciting, cutting edge work and discussions that we all need to be having. So thank you very much. I hope you all have a wonderful morning, evening, day, and look forward to being in touch.